with acute muscle strains. And then, Robert, maybe if you could mute yourself until it's your turn, right? And then just talk about a few of the other diseases just to kind of remind you, but in no way is this going to be a comprehensive review of metabolic diseases of the muscles. So let's start here. Dan, does muscle density, that is fatty infiltration of the muscle, correlate with physical activity?
Feels like a trick question, but I'm still going to say yes.
Okay. Yeah, on CT, it does correlate with physical activity. And there's a paper recently published in Skeletal Radiology that shows that if you follow patients after hip arthroplasty, those that exercise get less fat replacement within their muscles than those that don't. So our thoughts concerning fat replacement in muscles, sarcopenia, is probably correct, and that is predominantly due to inactivity of muscles. Okay, so if we look at MRI of the muscles, this is a review from radiographics from 2018. They divided disease into atraumatic, which include abnormal anatomy with normal signal like anatomic variants, edema, which can be from autoimmune, paraneoplastic, or drug-induced myositis. These are symmetric, or it can be from infection, radiation-induced myositis, and myonecrosis, which tend to be focal but asymmetric. And then there are masses, primary neoplasms, metastases, and some benign diseases, lipomas. And most of these we've kind of covered in the review of soft tissue masses. And maybe if we have time, I've got a bunch of other mass lectures, but we usually don't have time in the year to get to those. And then atrophy, muscular dystrophies, denervation, myopathy, and sarcopenia. Okay, muscle tears. Now, there are a bunch of classification of muscle tears. The three in this review article from Germasi include the modified Peetrons classification, which is a pretty common classification used in radiology. Grade 0 is where you may have symptoms, but the MRI is negative. Grade 1, you have symptoms, but there is edema, but the architecture of the muscle itself is still intact. Grade 2, you get architectural disruption with edema, usually indicating partial tears and hematoma formation within the muscle. And then grade 3, you have a complete rupture of the muscle. So this is a very common, probably the most common grading system. But as we'll see in this lecture, it's one that's not recommended as much in current practice of sports medicine. Then there's the Chan classification, and there are others as well. Grade 1, you have a strain where less than 5% of the tendons are disrupted with edema, and it's a little hard to determine the 5%. And can it be 5% all the way across the muscle, or is it just focal areas that don't include the entire width of the muscle? 5%. It's a little bit difficult to define this. Grade 2 are partial tears where you have fiber disruption, edema, and hemorrhage, similar to the previous classification, and grade 3, which is complete tears. Then there's a more recent classification called the Munich consensus, where grade 1A is fatigue, and you get negative imaging. Grade 1B is delayed onset muscle soreness syndrome, which typically can have a negative MRI, but typically you get a positive MRI, and the symptoms usually peak on day 2 after the exercise. Then there's grade 2, A and B. In this particular case, they have grade 2A, a spine-related neuromuscular disorder with or without positive MRI, 2B or muscle-related disorders. So this is one where they were interested in abnormal muscles with spine disease. Grade 3A are minor partial tears with fiber disruptions. Grade 3B are moderate partial tears. And then grade 4 are complete tears. And then you can just have a contusion or a hematoma with or without edema. Now, it's been thought in a number of papers in the past that if you have a hematoma within the muscle or a focal fluid collection within the muscle, which makes it kind of a grade 2 in the previous one, or in this case would be this contusion part, that had a worse prognosis and a longer term to getting back to play. Some recent studies suggest that fluid collections within the muscle actually don't delay return to play. So that's a little bit controversial, of which there'll be a number of other controversial things that we'll talk about. And the most recent one is the British classification, the BAMIC classification, where you can have muscle tears 0, grade 0s, where you have soreness with a normal MRI. Grade 1 are small muscle tears, typically involving the fascial edema, and usually less than 5 centimeters in length. 1B is muscular tendinous junction injuries. And then there's grade 2, moderate muscle tears. You get peripheral muscle edema involving greater than 50% of the muscle, internal edema, cross-sectional area from 10 to 50%. And then 2C is edema extends into the intramuscular tendon, not the extramuscular, but the intramuscular tendon. And we'll talk about this a little bit at length. In grade 3, you have more extensive muscle tears, greater than 50% cross-sectional areas, including the muscular tendinous junction, greater than 5 centimeters in length. And then grade 4 are the complete tears in this classification system. Using the British classification system, if you look at, and it's primarily designed for the hamstrings, but if you use it looking at the adductor longus for athletic injuries, you get about 45% are grade 1, 20% are grade 2, 10% are grade 3, and about a quarter are grade 4 injuries. And then return to play, grade 1 is about 2 weeks, grade 2 to 3 up to 6 weeks, grade 4 is greater than 6 weeks. So, and I'm sorry, I can't find the reference here to this, but there was a paper that this was described in, and I apologize for not having that reference. And then there are a number of papers looking at hamstring tears, which is really what this grading system was really designed for. There's one from 2018. There's actually an earlier one that first described it, but when you talk about return to play, there's one in 2018, 19, 21, and 22. There are probably others, but these are the key ones that I've seen referenced kind of repeatedly. So I'd like to go through each of these. And so the Wagenstein's paper basically looked at hamstring tears, graded them with the British classification, and is what actually they graded them with the Peetrons, the Chan, and the British classification. This is in the Journal of European Radiology, but is mostly American authors. And that what they found is there was a wide overlap between variations within the grading classification categories of all three. Therefore, none of the classification systems could be used to protect return to sports in their sample of MRI positive hamstring injuries. So they felt that you could detect the injuries, but that the grading really did not have an effect upon, or did not correlate with return to play. So that was the first paper. So then other people took up the gauntlet here, and the British came back into this with the British Athletic Guidelines. And it's what they said, that there are kind of three things that you should look for in terms of return to play. One is if the injury is predominantly on the peripheral portion of the muscle, as we see here, in which case it's basically 2 to 3 weeks to return to play. You can have a deeper tear or muscle edema involving the periphery of a muscle unit, in which case time it's about 6 to 8 weeks. the worst prognosis from them was if the actual edema involved the intramuscular tendon, which could increase the delay in healing to 2 to 4 months. So the British guidelines were to look at the location as well as the size of the tear. And you could use the whole thing, but in those that had type C or involving the intramuscular tendon, then you should delay return to sports for 2 to 4 months. And then here is from 2021, published in the British Medical Journal Open Sports and Exercise Medicine Journal, and they had 2 basic results. Hamstring muscle injuries extending into the intramuscular tendon, categorized as British athletic muscle grade C on MRI, or are associated with longer time to return to full training and increase the re-injury rate of elite players in English football or soccer. And most hamstring muscle injuries involve the distal biceps and involve both the long and short heads. So that's where the common injuries are. So they kind of confirmed that involvement of the intramuscular tendon is very important for return to play. So this is in 2021. And then here's an article from the journal Science of Scientific Medicine and Sports, where they also used the British classification, and they looked at tears that extended into the intramuscular tendon, and they found that they did not impact return to play or impact the re-injury rate. And they found actually the bulk of the injuries, the re-injuries occurred in low-grade lesions, and the injuries tend to occur within the first 2 months after returning to play, which is kind of interesting that they said the majority were these low-grade lesions, because the next thing they said is that the British classification system did correlate with the time to return to the play and re-injury rates. So I was a little confused reading this paper. I guess the majority of injuries were low-grade injuries, and there was a statistical, even though most of the injuries are low-grade, those that were higher grade had a higher rate of re-injury rates if you didn't wait. Now the NFL has taken up the British classification based upon these papers, and their recommendations for the imaging include this for MRI. So they have specific sequences that they recommend. You have to really image the entire muscle and its insertions, as you can imagine. And what they would like to see in the analysis by the radiologist is do the BAMIC grading system, determine where the injury is localized, proximal or distal, and whether it involves primarily the myofascia or the periphery or the myotendinous areas, myotendinous being more severe than just the peripheral lesions, measure the approximate length, estimate the cross-sectional area, the involvement of the edema on the edema-sensitive images, and then assess any secondary findings, including neurologic involvement, which I'll talk briefly about in a minute, soft tissue hematomas, and secondary muscle involvement. Okay, and again, this is just a review of the British muscle injury classification system. So let's look at a few other things and a few cases. This was a paper from 2012 looking at signal changes in hamstring muscle injuries. And they found that the things that correlated with muscle tears on MR was an increase in the tendon size due to edema, surrounding edema, and also whether there's marrow involvement or not. That if you have increase in size, if you have surrounding edema extending into the surrounding soft tissues and involvement of the marrow, that was a worse prognosis. and increased risk for symptoms. Now, as far as treatment of injuries, this is a paper from 2008. If you have proximal tendon avulsions, that typically requires early surgery, though I've seen a number of professional players with proximal tendon avulsions of the hamstrings, which were treated conservatively and went back to return to play in the same season. So yeah, a lot of it depends upon the degree of displacement. And then muscle tears really are non-operative. Okay, Elior.
Okay, we have a 24-year-old male, possible hamstring tear. In the left, yeah, we see edema and the intramuscular fluid collection.
Okay, just see there. Now, if we go to the axial images, there's one cut. Like this is the area where we're a little bit above it here, but we see a little bit of edema right there. If we go to the next cut down, what I want to show here is that here's the tendon, and that you've got here's part of the intramuscular tendon here, which we can see edema there. So if we go back again, there's that tendon. We're inside the muscle now. Now we're seeing a little bit of involvement of the tendon. So this would be put it into the C category. If we go farther down, now we see the tendon is very abnormal. There's two tendons here, but this is a lot of increased signal with edema around it. If we go down a little to the next cut, we're starting to see the tendon again now, but it's thickened with a lot of edema. Here we can see a fluid collection. And if we go down a little bit farther, we're starting to see the tendon come back around the fluid collection. And here further down, we can see the tendon next to the fluid collection. So this is a patient who would have a positive tear of the intramuscular tendon, which many people, but not everybody, believes is a risk for re-injury if you bring the patient back too early. And the British now recommend 2 to 4 months of rest before bringing the patients back who have intramuscular tendon tears. And again, this is the biceps tendon, and the vast majority, as stated in that one paper, are actually distal biceps injuries. Okay, Robert, what do you think of this case?
All right, so here, again, it looks like there's some edema in the biceps femoris, and there's a lot of fluid, and it looks like a tear of the proximal tendon there.
Yeah.
Or the mid-proximal tendon.
So the other thing that can happen, which is one of the secondary things, is you can injure more than just the tendon when you have these kind of injuries. And this looks a little bit different from the other edema patterns that we've seen so far. And we've seen a bunch of other muscle injuries throughout the entire year here. So this looks a little different. This is more uniform, not quite as bright. We don't see any focal fluid collections within the muscle itself, and it's sharply defined along the boundaries of the muscle. So this looks a little bit more like some of the neural problems. Look how sharply defined it is, however, in here in the muscle, depending upon the which nerves are innervating the muscle. And this turned out to be acute biceps denervation due to an injury to the muscle coming off the, what's the main muscle? Nerve coming down here. Sciatic, yeah, coming off the sciatic nerve, which innervates the biceps. So this is a denervation that can occur when you have proximal tears. And this is just a paper about the denervation. Now, another thing that's been looked at a lot, and this is primarily now not in the hamstrings, but in the rectus femoris muscle or exercise-related areas of bone marrow edema, is kind of divided into type A, B, and C, where A is just at the muscular tendinous junction, where this is the main tendon coming into the rectus femoris proximally. That's the tendon, and here's the area of edema. You can also just have injury peripherally around the muscle, as also was referred to in the British classification system, or you can have both, types A, B, and C, And again, this was primarily done in soccer players. So this is an example of the type A, where you have the edema just around the tendon and the musculotendinous junction. Type B, where it's more peripheral. And then a type C, where you have both around the musculotendinous junction and the periphery portion of the muscle. And this turns out to be about 11% of professional soccer thigh injuries, and acute, especially the acute subfascial injuries are quite common. And the subfascial injuries actually have a better prognosis than the deeper injuries. Tayson?
All right, 73-year-old female with left hip pain. Looks like you have an avulsion injury of the indirect rectus femoris head there.
Yeah, I didn't mean to put this one in here. You're right, exactly. So that's indirect head tear, but that's a. And then here in this case, we can also see some musculotendinous injury, but this isn't predominantly and we can see muscle injury here coming along the rectus femoris. So here we have both a tendon as well as a musculotendinous junction injury. Now, the one thing to notice here is the intramuscular tendon. Oh, that's why I put this in here. Here's a case where there's the intramuscular tendon. Looks pretty normal here, looks pretty normal there. But in this particular area here, we can see it's markedly thin, and in some images, a little bit wavy in that area there. Oh, no. Oh, I'm sorry. Here, this is that part. This is just partial volume of that. And well, there's supposed to be another one here showing an intramuscular tendon tear, which has a very wavy appearance, but I left that out. Sorry about that. And here's another article that looked at intramuscular degloving injuries to the rectus femoris, which are these injuries really at the musculotendinous junction, predominantly proximally here. And then this just shows that area centrally here where you can get the injury to the surrounding muscle at the musculotendinous junction. Okay, Dan, what do you think of this case?
Okay. Looks like there is increased signal of like the vastus lateralis. Oh, this is the wrong area.
I'm not sure where you're
I was looking more anterior.
up here.
Yeah. But
Yeah, I think the signal's okay. It's a little bit of the shape here. Notice that's where the marker is. This is a patient who has a mass. It tends to increase when they contract their thigh muscles and relax when they don't.
oh my.
So this is a little bit of a deformity of the muscle here and there. And I don't have contraction and non-contraction images there. The signal intensity is normal, so it really looks like normal muscle. And this is called fascial herniation. Okay. Elior.
Okay. Prior fasciotomy for compartment syndrome, direct trauma 6 days ago with increased pain and swelling. So in the lateral left thigh, I mean, the muscle, yeah, it looks like it's it looks like it's herniating out of the fascia, so another herniation.
So another fascial herniation. Yeah. So so occasionally you'll get images looking at masses, and you'll see it these fascial herniations. Okay, Robert, you're going to be moving to Santa Barbara. You might be going horseback riding, so this is for you.
Well, we did see a few of those injuries. We have a 41-year-old female, pain 2 days after being stepped on by a horse. Looks like there's a lot of edema within the musculature and superficial, looks like a fluid collection, maybe a hematoma there.
Okay.
Yeah, similar here. It looks like a intramuscular hematoma. Yeah, maybe a defect in the fascia there peripherally and some fluid extending peripherally.
Yeah, so that was a crush injury. So you can have direct trauma injuring the muscle, not associated with sports imaging. Okay, Tayson.
All right, 11-year-old female, generalized muscle weakness since infancy, areflexia, elongated face, ptosis. Okay, so I guess there is some piriformis atrophy in those hips, and the hamstrings muscles are all atrophied as well.
Yeah. So what do you think?
I'm not sure.
Yeah, well, I wouldn't really be either. So they decided to biopsy this, and this is a thing called central nuclear myopathy. It's a congenital myopathy, another genetic, abnormal gene, which leads to abnormal metabolism within the muscle. There are a bunch of them, and that's more kind of a pediatric area, but we don't generally in general musculoskeletal imaging, we don't deal with a lot of these. I'm just going to show some of them just so that you can think about them, and then they're then generally diagnosed by biopsy, and then the treatment can be very different depending upon what the actual biochemical abnormality is.
Okay.
Dan?
21-year-old female, progressive gait disturbance since childhood, long face with open mouth, high arched palate, lumbar lordosis, bilateral wing scapula, facial weakness with weak eye closure, neck flexion, weakness, gait disturbance, disturbed toe and heel gaits.
Otherwise normal.
Otherwise normal. Okay, yeah, so lots of fatty atrophy in the hamstring muscles
Yeah.
and also the calf muscles.
Yeah. Now, the first thing to think about on something like this is it symmetric?
Yeah.
If it's symmetric, then it's likely, highly likely to be a congenital lesion. If it's due to trauma or infection, like polio or something, they tend to be asymmetric. So once it's symmetric, you kind of have to think more in terms of something that's congenital. So it needs, and this is just a congenital myopathy, needs to typically be diagnosed by biopsy. Okay. Here they are.
36-year-old female, now tubular myopathy, myasthenia gravis. Yeah, here you see a symmetric, just diffuse atrophy, especially in the thighs.
Yeah, so this is central nuclear myopathy. And there are a whole bunch of neuromuscular diseases that can affect them, the muscles. There are entrapment neuropathies, a lot of hereditary things that we're not going to go through. Guillain-Barré syndrome, Friedreich's ataxia, and there are just a lot of muscle diseases, and with a number of, and more, there are more and more as we go along, and a lot of these are going to be divided into multiple ones as we get more information concerning mutations and the biochemical basis of these diseases. Robert.
All right, so we have a 10-year-old male, progressive extremity weakness for 6 years, some calf pseudohypertrophy, positive Gower sign, don't remember what that is, lumbar lordosis, some tightness of the IT band and tightness of the calves, elevated CK, and active myopathy.
Yeah, I forgot to look up Gower's sign. Forgot as well. So what do we see here?
All right, here in the legs and gluteus maximus, there's a fair amount of atrophy.
Yeah. And so this again looks like it's probably going to be some kind of congenital syndrome. And then it was. So genetic analysis. And this was one of the many causes of Duchenne's muscular dystrophy. Okay, Tayson.
All right. 32-year-old female. Yeah, there's essentially no muscle that hasn't been atrophied that we see. It's almost complete atrophy of the legs, you know.
Yeah, this is called limb-girdle muscular dystrophy. Again, symmetric. So, yeah, with this history, you need to think in terms of some sort of congenital syndrome.
Okay.
Yep. It's autosomal recessive, and obviously, initially, they have gait disturbances. Okay, Dan.
21-year-old female with muscle weakness. Looks like we have asymmetric muscle atrophy of thigh muscles.
Here, it looks like there is some asymmetry.
Yeah. Okay.
Yeah, but this was another muscular dystrophy. Yeah, it's still involving both sides, even though there is a little bit of asymmetry associated with it. Whereas obviously, if we're just trauma, it would just probably be one. Well, it can be both sides, but usually it's only one side. Okay, Elior.
57-year-old male, dysphagia for 3 years, progressive muscle atrophy, weakness, atrophy of the shoulder girdle, muscles, positive posterior scapular depression sign. Father and brother, similar signs. Yeah, we see marked atrophy of the right posterior thigh muscles.
So that's another muscular dystrophy. So they can occasionally be asymmetric, but generally, if it's asymmetric like this, you should think more in terms of a neurologic injury. But in this case, it was a muscular dystrophy. Yeah. Robert.
All right, so we have a 44-year-old male with weakness, some mild fatty atrophy. It looks like in the calf musculature,
Yeah.
most prominent there.
Yeah, it's always progressive weakness. Again, it's just something where you'd have to be concerned about some sort of a genetic problem. And this was X-linked recessive neuropathy. Okay, Tayson?
All right, 27-year-old male, both leg weakness and atrophy for 1 year, toe gait disturbed on left, heel gait disturbed bilaterally, pes cavus bilaterally, and distal leg atrophy, generalized areflexia. All right, so definitely atrophy of the rectus muscles and I guess adductors and gracilis.
Okay, so you'd be worried about some sort of a congenital syndrome, I guess, here. Okay, so they did a biopsy.
Okay, abnormal dystrophy.
So they really didn't show a problem with muscle. So come back again, what other possibility could do this? It's symmetric. Certainly, if you have something that symmetrically involves the nerves, that's a possibility. And this was Charcot Marie Tooth syndrome. Okay. Dan?
72-year-old male, lower extremity weakness for 5 months, painful gait disturbance for 1 year, physical exam, diffuse muscle atrophy in the leg and foot with pes cavus deformity, normal sensory function, disturbed toe and heel gait. EMG showed denervation or denervation process of the lower extremity. Two brothers expired with the same symptoms. Okay. So the hamstring or the calf muscles, as well as the glutes, look symmetrically.
It looks pretty similar to one of
Yeah.
the previous muscular dystrophies
Yeah.
we saw. But this is a patient with Charcot Marie Tooth syndrome, which we talked about last lecture.
Yeah.
And so there are a lot of peripheral neuropathies, which can lead to mostly symmetric muscle atrophy.
Okay, 36-year-old female, left lower extremity weakness for 4 days. The left thigh muscles, we see edema, lots of subcutaneous soft tissue edema in the fat. So on the other side, okay, let's see.
So that's pretty fast. That probably these are T1s.
Bones look
There's some asymmetric volume of the muscles.
okay.
And then you also see that there's coxa
Chicago.
valga, right?
Yeah.
Bilateral disease, but a little bit asymmetric.
Mm-hmm. I mean, myositis, just after a week, maybe an infection.
Okay. On both sides. And then here we can see that there are areas which don't enhance centrally. What does that make you think about?
Fluid, abscess.
Could be fluid or it could be dead muscle tissue here.
Mm-hmm.
So,
Necrotizing fasciitis, maybe.
okay, good. Now, so whenever you see this and you wonder about that, what are the things you think about?
So, like neck fascia, like an infection. Could
Okay,
be
infection. This would be a pretty diffuse infection on both sides, but that's right.
like a tumor with like internal necrosis.
It's a lot of tumor here.
Yeah.
Tumor, but I guess so. Is in one kind of one side or one compartment. You can think about compartment syndromes. But the thing in this day and age that should come first to your mind is drug reactions. And so the history is they take sleeping pills regularly, took a double dose and fell out of bed. And here we can see that there is abnormal renal function. Myoglobin is very high, so you've got a lot of destruction of muscle with a lot of muscle particles in the blood, which are probably destroying the kidneys. CPK is very high. LDH is very high. And this is drug-induced rhabdomyolysis. And there are a lot of drugs that can do it. So in this day and age where a lot of people are taking drugs and there's a lot of overdose, this is something you should always remember. Okay, Robert.
All right, we have a 46-year-old female with schizophrenia and bipolar disorder presenting to the ER with a 2-day history of headache, blurred vision, left leg and hip pain, and new painful right neck mass. CPK was very elevated on admission, and we have some selected images of the brain, spine, and pelvis. All right, looking at the muscles of the posterior rightward aspect of the neck, there's a lot of edema and inflammatory change there. Also some of the masticator muscles on the left, and a lot of, again, fluid and edema in that, the muscles of the hip on the left, less on the right. Gluteal, a lot of gluteal edema, and it's like some myositis.
Okay, so here's post-contrast, and there's a lot of the area inside the gluteal muscles on the left here are not enhancing, which makes you worry. So this turned out to be rhabdomyolysis, secondary also to a drug reaction. You know what? Let's stop here.